can start the presentation now. So just before we go ahead, we'd like to talk about Cardiocare Multi-Specialty Hospital. It's one of the pioneer hospitals leading in clinical and interventional cardiology in Abuja and Nigeria at large. We also have specialties such as endocrinology and diabetology, neurology, nephrology, and other various internal medicine and specialist care can be accessed in Cardiocare Multi-Specialty Hospital. For a matter of fact, everyone doesn't need to go abroad for advanced cardiovascular health care. The aim and the goal of Cardiocare is to end medical tourism in Nigeria, and we believe that step by step we're on the right track to making sure that dream comes to pass. So the part of services that we offer in Cardiocare includes cardiology, nephrology, and endocrinology, and other specialist consults like rheumatology, pulmonology, general internal medicine, and comprehensive medical checkups. We also take referrals for cases that you cannot manage, but for now, we'll just have to go into the presentation itself. Today's topic, we'll be talking about chest pain and acute coronary syndrome, evaluation and treatment in Nigeria. And I and my senior colleague here will be taking you on that, and we hope that by the end of this presentation, we should have made valuable impacts in educating our fellow colleagues on things to do when you have such a case. So the very first step to outline our goals of this presentation is to understand chest pain and acute coronary syndrome, detect conditions correctly and promptly, to treat diseases and causes, and to ensure that we prevent any further complications that could arise from this case. So we've prepared a chest pain algorithm for you that we'll go through. So the very first thing that we want to talk about is chest pain and how to characterize chest pain.
Thank you, Dr. Fortune. Again, I'm Dr. Adefila, Rafiu, a consultant physician and cardiologist. Chest pain is one of the most common symptoms that bring people to the emergency. The most feared cause of chest pain is if it's due to a cardiac cause, that is due to a problem with the heart. To evaluate a patient with chest pain, and you are looking at a cardiac cause, you need 3 criteria. 1, is this chest pain, is it substernal, that is retrosternal or left-sided? And is it a form of discomfort or pain? It depends on what the person says. Others will not describe pain, they just describe discomfort. This particular discomfort or pain they are feeling, is it provoked by exercise or exertion or emotional stress? And is it relieved by rest or nitroglycerin? Now, when you have such suspicious chest pain and you're thinking it's cardiac, we tend to divide them into 3 categories. Typical cardiac chest pain will meet the 3 criteria I already outlined. Atypical ones, usually 2 out of 3. And generally, if you have 1 out of the 3 or none at all, it's likely non-cardiac chest pain. So for evaluating a patient with chest pain, we want to ask what is the location of the pain. People describe various locations. So we tell you pinpoint that what they mean by chest pain is just below their left breast. Others will just say is central chest. Others will tell you is left-sided, right-sided. You want to know where exactly is this pain. Also, you want to know what brings the pain up. Is it physical exertion or emotional exertion? Some will just describe the activity they were going through before the pain come up. Doctor, I used to take a walk every morning. Nowadays, if I take my 1 kilometer out of my 5 kilometer, I have this chest heaviness or retrosternal chest pain that comes up until I have to stop before the pain goes away and all that. Relieving factors for typical chest pain is rest or nitroglycerin. Other people that come with other types of pain that are non-cardiac may describe things that relieve their pain, like use of antacid, use of simple analgesic and all that. Typical cardiac pain varies in episode, but if it is typical angina, for example, it usually lasts less than 10 minutes, usually for most people less than 5 minutes. After some rest, it goes away. Then typical pain related to the heart, cardiac chest may come with diaphoresis, dizziness. Patient may have associated cardiovascular risk factors like hypertension, diabetes, and the like. But these are some signs that the pain the person is describing is not likely from the heart. When the pain is sharp and the patient can pinpoint a location. Also, when the pain is reproducible, the patient can tell you, when I touch this place, with one finger, I can feel the pain, not likely from the heart. Submammary pain, like somebody saying the pain I have is just below my left breast and it goes towards the side and all that, is also less likely to be cardiac. We're not saying people cannot have atypical form of chest pain that is still cardiac, but we're saying that these are less likely. Pain that lasts few seconds. Some say, I just have this sharp pain, I hook my chest and it goes away without any issue. Or pains that are lasting long duration, more than 6 hours or days, they are less likely to be cardiac. Focal tenderness, as I talked about reproducible pain earlier. Pains that are related to movement. Some people will tell me this pain comes when I change position, or related to food, either when they're taking certain meals like yam, beans, and the like, or they eat late, or when they are fasting. Pain that is also less likely to be cardiac will be especially people with no established cardiovascular risk factors like hypertension, diabetes, or smoking. So in cardio care, we have this pretest probability that we use. We tend to look at patient risk factors background. If they have pretest risk factors like hypertension, diabetes, smoking, peripheral artery disease, previous cardiovascular diseases like stroke, dyslipidemia, or family history of ischemic disease in a young person, we want to know. Such people, if they have 2 or more of these risk factors, we say they are high risk. They are intermediate risk if they have 1 risk factor, and they are low risk if they have what? No risk factor at all. We have this algorithm in cardio care that we use to evaluate a patient with chest pain. The algorithm is simple. We want to try to use that to explain how to evaluate a patient with chest pain for you. Next slide. So in this simple algorithm, you can see the first thing you do when a patient comes with chest pain is that you need to do a 12-lead ECG within 10 minutes. If the patient has ongoing chest pain, somebody comes to you, 5 to 10 minutes, get an ECG. While you are doing that, do a quick evaluation of the patient. You also want to know their cardiovascular risk profile, their risk factors, their basic biomarkers, and all that. Now, if such patients are high risk, they have more than 1 risk factors, as we have highlighted earlier, and their ECG is normal, so you may want to do an echocardiogram and a troponin. Though sometimes the initial ECG for such patients may be normal, but you repeat it in 3 to 6 hours, especially if they have ongoing pain. We've seen instances where people come, high-risk patients, ongoing chest pain, normal ECG initially, 6 hours later or 12 hours later, the troponin is up, and you now diagnose them with their ECG is bad rather, and their troponin is up. You diagnose them with ischemic disease. Of course, if they have cardiovascular risk factor and their ECG is also abnormal, you want to do what? Echocardiogram or troponin level. If the troponin is positive for these high-risk people, or echo is suggestive of what? Of ischemic disease, you admit them into intensive care and you get a coronary angiography and start the acute coronary syndrome protocol. However, if such high-risk patients, their troponin is negative and their pretest probability for coronary artery disease is still high. For example, somebody has 2 risk factors for coronary artery disease. Their chest pain is typical, as we said earlier. So the pretest probability of such a person with risk factors and typical chest pain is already high. What you are seeing is suspicious of acute coronary syndrome. You just go straight and do coronary angiography, even when the troponin is negative. However, there will be some patients with intermediate risk. Who are these intermediate pretest probability? Who are these people? They still have risk factors more than one, but they're coming with atypical chest pain. You understand? Especially when they don't have ongoing chest pain now. Such people, you may want to do what? A stress test for them first before you go further to invasive investigation. So that's it. But if the patient is low risk, they are coming with non-cardiac chest pain. You want to evaluate for other causes of chest pain, especially if they have negative troponin. Look for other causes of chest pain. Now, for people with intermediate risk factor, they maybe just either hypertension or diabetes. If they have a normal ECG and the troponin is also negative, you will also follow the same pathway as we have highlighted earlier, except they have high suspicion of what acute coronary syndrome, in which you go to acute coronary angiography. If they have low risk, you just look for other causes of cardiac chest pain, other causes of chest pain apart from cardiac and all that. But the last group will be those that have they don't have cardiovascular risk factor at all. They are not hypertensive, neither are they diabetic and all that. Such people, when they come to you and you have done the initial evaluation, you've done the ECG, if the ECG is abnormal, an abnormal ECG, you check their ECG, you check their echo and troponin. If the troponin comes out negative, you follow the pretest probability as we highlighted earlier. High pretest probability, you still go ahead and do coronary angio. If they have intermediate, you do a stress test, and if they have low pretest probability, you look for other causes of chest pain outside of cardiac chest pain. But if such patients already have a positive troponin, you may, even if they have low risk factor, already because their ECG is, their troponin is high, you may want to go straight to coronary angiography. For people with normal ECG and negative troponin, such people, especially when you have repeated it after the initial troponin and it's still negative, such people you can safely look out for what other causes of chest pains outside of what cardiac causes. So that's the way we look at this. Is our own simple algorithm in cardiac care that we use to evaluate patients with chest pain. This is not cast in stone. There are instances where people may look seemingly low risk with initial normal ECG that as later the troponin and ECG goes back. That's why you need to repeat it afterwards. 3 to 6 hours to recheck again before you can safely say there is no cause for alarm. So we are going to go through some cases just to highlight some of the causes of chest pain, the importance of getting the initial ECG and the blood work of the evaluations and all that before we go straight to acute coronary syndrome. Dr. Fortune will continue with case 1.
Okay, thank you very much, Dr. Adefila, for that enlightening talk. So the very first case we'll be talking about is a patient who came in with complaint, 56-year-old male, who came in with complaints of worsening sharp chest pain of 2 days duration, aggravated by inspiration, lying flat at night, relieved by sitting up, radiating to the left arm and the back. There's associated nausea, mild fever, and tachypnea. Patient is a known hypertensive on bisoprolol, X-Forge, aspirin, atorvastatin, no history of diabetes, no smoking or drinking. On examination, his pulse rate was 102 beats per minute, BP 146/76, JVP was not raised, heart sounds were 1 and 2 only, respiratory rate 22 cycles per minute, oxygen saturation 98% in room air, and the normal chest examination findings. So the first question we will ask is, what kind of chest pain is this? Is this a typical chest pain? Is this an atypical chest pain? Is this a non-cardiac chest pain? Or the first answer is, I don't know.
So we'll await response from the audience. You can send your response to the chat.
But just to note that non-cardiac chest pain doesn't mean that it's not from the coronaries. It's just that it's much less likely. So if you want, we can go over the question again, just so that there can be so that you can understand it more. So the patient is a 56-year-old male, came in with worsening sharp chest pain of 2 days duration, aggravated by inspiration, lying flat, relieved by sitting up, radiating to the left arm with associated nausea, mild fever, and tachypnea, a known hypertensive, no smoking, tachycardia, BP a bit elevated, heart sounds S1, S2, normal respiratory findings. So is it a cardiac chest pain? Is it a typical cardiac chest pain, atypical, non-cardiac chest pain, or you don't know? So what do you think? Please leave an answer for us in the chat. Okay, so we just realized that our slides were not showing. We apologize for that, but we'll still revise the algorithm again. And please, if you have any answers, please just put it in the Q&A for us, please. Thank you very much. Okay, so we're having some answers here. Some people say it's a cardiac chest pain. Okay, some people say it's typical. Some people say it's atypical. Some people say I don't know. That's nice. Okay. Okay, so these were the investigation for the patients. We did an ESR and a CRP. ESR was 90 millimeters per hour, elevated. High sensitive CRP was greater than 5, also elevated. The troponin was less than 0.1 nanograms per mil. Full blood count was quite unremarkable, except the total WBC count that was elevated. EUCR unremarkable. All parameters in the lipid profile were within normal limits. Fasting 95 milligrams per TL normal. HbA1c normal. This is the ECG for the patient. So
we're going to leave the ECG on for like a few seconds so that you go through it before the next question. You can send your comment to the Q&A. We need to look at it at the Q&A.
some people say atypical chest pain. Former Bianca Osuji, atypical. Kevin Steve Igama, it's a cardiac chest pain because he has associated risk factors. Ramat Giwa said it's an atypical, likely angina. So we'll see what the answer says. So I hope we've taken a picture in our heads of this ECG because we'll still come back to it. So the final diagnosis. Another question, what is the final diagnosis for this question, for this case? Is with an acute myocardial infarction, acute pericarditis, pulmonary embolism, costochondritis / musculoskeletal pain. What do you think? Please leave your answers for us in the chat box. In the Q&A, sorry. Someone said acute MI, okay? Keep the answers coming. Keep the answers coming. We'll still see what the real answer is. Someone says acute MI, okay, okay. That's okay. Acute MI, acute MI, acute myocarditis, okay. So let's see what the answer says. So the answer is actually acute pericarditis. So why is it unlikely to be an acute coronary syndrome or an acute myocardial infarction?
Thank you. Thank you for all those that responded to the questions. Now again, to recap on how to look at chest pain, we said the typical chest pain has three characteristics. One is a retrosternal chest discomfort most times. It could be pain, it could be discomfort. By nature, is squeezing or heaviness. It's not usually described as sharp. The second point we said is that it's precipitated or aggravated by exertion or emotion. And the third point we said is that it's relieved by rest and or with nitroglycerin. And we said if we have a patient with the three characteristics of chest pain, that is typical cardiac chest pain. If you have two of those characteristics, that's atypical pain, atypical cardiac pain. But once it's just one or none of those characteristics, we say is what is likely non-cardiac chest pain. So for the guest who presented, we can see that he had a sharp retrosternal chest pain. It's sharp, but it's aggravated by what? Breathing in and what? And lying down, which is not one of the characteristics of typical chest pain. And it's also what? Relieved by what? Sitting forward. So which is also not one of the characteristics of typical chest pain. So we can see that this is not typical angina or typical cardiac pain. So this is the least you can say is either is atypical or non-cardiac in this case. So this is likely a non-cardiac chest pain. That was one. Number two is that the ECG that was displayed. Go to the next slide. Go up. No, go down. The ECG that was displayed showed the typical features of pericarditis, acute pericarditis. We're going to show you what the typical features of acute pericarditis look at. Now, look at this ECG. We can see that the PR segment here, that is the segment between the P wave and the QRS. We can see that it's sloping downward here. And that's uniform across all the waves. You can see it sloping downward there. You can see it here. Then if you look very well too, you will see some ST elevations that look concave upward here. There's some ST elevation, there is some concavity on this ST elevation here. So widespread PR depression and concave ST elevation is typical for acute pericarditis. So if you look at the characteristics of the pain that this patient presented with sharp retrosternal pain, looking pleuritic, that is worse on inspiration and on lying down, relieved by rest, sitting forward. And then you look at the inflammatory markers the patient had that were elevated. You combine it with typical ECG findings of acute pericarditis. The diagnosis for this patient is acute pericarditis. Also, the troponin was normal. There is no way somebody will have extensive myocardial injury that they will not what? They will not have what? Elevated troponin as you see in acute MI. So, but troponin normal, ECG not showing typical features of acute MI, and the other history suggest an ECG showing features of acute pericarditis. The final diagnosis based on this is what?
Acute pericarditis. And based on these results, the cath lab was deactivated. The patient was placed on bed rest, NSAIDs, and antibiotics. By day 4, he was less breathless with minimal chest pain. Oxygen saturation was optimal between 97 to 99%. The erythrocyte sedimentation rates reduced to 30 millimeters per hour, and the total WBC count also reduced. Okay. So the second case we'll be talking about today is a 40-year-old female who presented with complaints of difficulty in breathing, worsening, sharp chest pain of 2 days duration, aggravated by inspiration, lying flat at night, relieved by sitting up, associated with dizziness and fatigue, pain radiating to the left arm and back, no known relieving factors. She had a myomectomy at the referring hospital 2 weeks prior to presentation, no history of smoking or drinking. The pulse rate was 132 beats per minute, BP 96/78, JVP was raised, heart sounds S1, S2, S3 with gallop rhythm and a loud pulmonic component of the second heart sounds ahead. Respiratory rate was 32 cycles per minute and the oxygen saturation was 88% in room air. The chest was clear on auscultation. So what kind of chest pain is this? Is it a typical cardiac chest pain, an atypical cardiac chest pain, a non-cardiac chest pain, or you don't know? Can go over it again. 40-year-old female, difficulty in breathing, worsening chest pain of 2 days duration, aggravated by inspiration and lying flat, relieved by sitting forward, radiating to the arm, had a previous myomectomy 2 weeks prior to presentation, pulse rate 132, JVP was raised, heart sounds S1, S2, S3 with a gallop rhythm, respiratory rate 32 cycles per minute, SpO2 88% in room air. The chest was clear on auscultation. So what do we think? Is it a typical chest pain, atypical chest pain, non-cardiac chest pain? Please let us leave our answers in the Q&A box. So for the Q&A, some people are saying it's an atypical chest pain. Some people say it's a non-cardiac chest pain. Some people say it's a typical chest pain, non-cardiac. Most people are saying it's a typical chest pain. Most people say it's a typical chest pain. So we'll see the answer now. Okay. So these were the laboratory findings on this patient. The D dimer was greater than 10, ESR 30, high sensitivity CRP less than 1, troponin 0.9, reference range 0.0 to 0.3. The full blood count unremarkable, ECR unremarkable, lipid profile fine, fasting blood glucose and glycosylated hemoglobin fine, urinalysis also fine. So now this is the ECG of these patients now.
So we wanted to look at this ECG over the next 10 seconds. Based on the history that was given, sharp pain, breathlessness, low oxygen, the troponin and D-dimer. Troponin is just mildly elevated. The D-dimer is markedly elevated. Look at this ECG and let's know what your thoughts are about the ECG. So what do you think the final diagnosis of this patient is? The acute myocardial infarction, acute pericarditis, pulmonary embolism, or musculoskeletal chest pain?
Is the answer in the Q&A? Let's see what the question said. Typical, non-cardiac, atypical, non-cardiac, typical, non-cardiac. Someone said PE, okay. Pulmonary embolism, okay. Pulmonary embolism, it seems like this one is a giveaway. Pulmonary embolism, okay. That's great. Pulmonary embolism. Let's see if you're right, though. Okay, so fine. The answer was actually pulmonary embolism. Okay, fine.
So again, we described chest pain earlier that can be typical, atypical, or non-cardiac. Typical chest pain has 3 features. Retrosternal chest discomfort could be heaviness, could be constricting. Retrosternal chest discomfort. Second feature is that It is aggravated by exertion or emotion. And third is that it's relieved by rest and or nitroglycerin. And for these guests, yes, there was a chest pain that is retrosternal. However, the aggravating factors and the relieving factors are not typical. The other thing, so the patient is likely having most likely a non-cardiac chest pain. The other issue is that the guest came in with breathlessness prominent in the presenting complaint, low oxygen, heart rate very fast, and there is a recent history of surgery. We know surgery and immobilization are risk factors for pulmonary embolism, and the biomarkers, troponin can be elevated in so many other conditions beyond acute myocardial infarction. We're going to make comments on that later. However, the D-dimer was markedly elevated. So this is the ECG. The typical ECG, one of the typical ECG findings, though not seen in the majority, it's not seen in all the patients, is this kind of ECG finding. You see S1, deep S wave in lead 1, Q wave in lead 3, and T wave inversion in lead 3. That's S1, Q3, T3 pattern. The other thing you can see is what we call right ventricular strain. You see deep T wave inversions in the anteroceptal leads, V1, V2, V3, V4, V5. These T wave inversions are just telling you that the right ventricle is crying out. So it's a sign of right ventricular overload, pressure overload. So once you see this, in a patient presenting typically with those symptoms we have described and the biomarkers we have described, you suspect acute pulmonary embolism. So that's why this is not acute MI.
So another case that we'll have, okay, sorry. So based on these results, the assessment was acute pulmonary embolism, and then the cath lab was deactivated. Diagnosis was confirmed with a contrast pulmonary angiogram, subcutaneous enoxaparin followed with oral anticoagulation as outpatient for 6 months was given to the patient, and the symptoms resolved completely. So we have to know that dyspnea, tachypnea, tachycardia, hypoxemia in clear lung auscultation are ones that we should be thinking of pulmonary embolism. It's more common than you think, and we should be we should understand how these things present. So now we're going to talk about the acute coronary syndromes.
So acute coronary syndromes are known as heart attacks. So the layman is a heart attack. Comprises of unstable angina and myocardial infarction. Generally, acute coronary syndromes are caused by either a rupture or fissuring of an atheromatous plaque on the coronary artery wall. It generally presents as chest pain or chest discomfort, though sometimes people can have a typical presentation, pain in the epigastrum that they may call ulcer pain. Others may not even have pain. They may just have breathlessness, especially in elderly folks or people that have underlying disorders like diabetes. They just have fatigue and breathlessness, and it will still be acute coronary syndrome. So sudden onset of those two in somebody at risk, you must start thinking acute coronary syndrome. So this is an atheromatous plaque. You can see the vessel wall. This is the normal vessel wall. You can see this. We used to say that the event you are seeing when somebody suffers a stroke or a heart attack is a process. The event you are seeing now is the final stage of the process. So over time, from endothelial injury to this vessel wall, an accumulation of lipids over time degenerates into this atheromatous plaque that is usually, for most times, stable. That is, the wall is stable for a long time until it becomes unstable and can rupture or break down. Once it breaks down, very thrombogenic material inside the plaque can come into the lumen and form a thrombus that can occlude this vessel lumen totally or partially and lead to what? Acute coronary syndrome. So this is just a simple way of explaining the pathophysiology of acute coronary syndrome. So for evaluating acute coronary syndrome, we want you to think in these 5 steps. The first thing is the presentation. Is this person coming with sudden onset chest pain and or upper epigastric pain, or as I said, atypical presentation like fatigue or sudden onset breathlessness in high-risk patients? Number 2 is that we want you to look at the ECG. Is the ECG positive for acute coronary syndrome? Number 3 is the cardiac enzyme positive? And number 4, are they typical at-risk individuals? That is, they have family history of premature atherosclerotic cardiovascular disease? Do they have diabetes, hypertension, or lipid? Do they smoke? Once you look at these 4 things, and everything is looking like, oh, this particular individual in front of me likely has acute coronary syndrome, I want you to go to the last step, which is urgent medical treatment and reperfusion if it is necessary. So we're going to take each of those steps one by one. We discussed chest pain earlier. We tried to tell you what typical pain is and all that. So when somebody comes with acute coronary syndrome, it's expected that you do a quick history and physical exam to confirm typical symptoms of ischemia. And you want to know their hemodynamic status. Are they in shock? Are they in acute heart failure with congestion? Do they need immediate? Are they in cardiac arrest? Like 2 days ago, we had a patient, acute coronary syndrome, presented to the hospital, sudden chest pain, came into our emergency, and within 5 minutes of being in the emergency, the patient went into ventricular fibrillation and arrested there and there. Of course, we resuscitated the patient, gave ICD, defibrillation shock. The patient survived, had coronary angio afterward, and is still alive. With 4 stents, and is still alive as we speak. So you want to know the hemodynamic status. Hemodynamic status will just be heart failure, could be cardiac. The patient can go into cardiac arrest, for example. The patient could be in shock and all that. So the next step is the ECG. This one should be done quickly. Immediately a patient comes anywhere in the world, not just in Nigeria. Immediately from the first clinical contact, 5 minutes to 10 minutes, you should have done an ECG. And it should not just be done, it should be interpreted. So anyone coming with acute chest pain, regardless of if it's MI or not, please get an ECG. Be sure of us that it's not MI. The other thing is you should do a troponin level. Troponin should be done at presentation. If your ECG and or your troponin are normal initially and the patient still has ongoing chest pain, you are required to do it again within 3 to 6 hours to detect the rise and or fall in what? The troponin level, and if the ECG changes are still evolving, because sometimes people may have an initially benign looking ECG that within few hours next you start seeing ST elevation and all that. That's why you need that repeat. So this is a way to classify coronary syndrome. If a patient comes with positive enzymes, generally, it's just telling you that the myocardium is damaged. So, and that's MI. So if the ECG of that person is positive for ST elevation, you say the patient has what? STEMI, ST elevation myocardial infarction. If the ECG is not showing ST elevation, but the enzyme is still positive, you say it's what? Non-ST elevation myocardial infarction. For people that have negative enzymes, that is, the troponin level is normal. If the person comes with what's it called? No ST elevation, no no obvious abnormality in the ECG, you may start considering that it's just a normal ECG and the patient does not have acute coronary syndrome. But if the person still has ongoing chest pain, especially severe enough to bring them to the emergency, you should consider what? Unstable angina. But there will be a group of patients that come with positive ECG, and the initial troponin level you did is normal. Such patients, you have to repeat that ECG within 6 to 12 hours sometimes 3 to 6 hours to confirm if it is just, and the patient may come very early. Like the guest I told you yesterday, that we had 2 days ago. The initial troponin was very normal. By the time we are repeating it the following day, the troponin was more than 50. So the patient may have come very early before the troponin start rising. So that's why you need to do that repeat, because it can still be MI, especially when the patient is presenting to you with ongoing chest pain very early from the onset of the chest pain. Other reasons can be because the patient has other causes of chest pain that can give you ECG abnormalities that looks like MI, like what? Pericarditis, for example. As I showed you earlier, somebody with concave ST elevation that is widespread on ECG. So this is the table that tend to sieve out how we classify patients. So we say positive enzyme, especially somebody that has the typical presentation, is MI. We just determine if it's MI based on if there's ST elevation or not. While if the enzyme is negative, it can either be normal, it could be unstable angina, especially if the patient is coming with typical chest pain, or if the ECG is showing ST elevation and the enzyme is negative, you have to repeat it again, because you also have to keep in view other causes of ST elevation beyond MI2, like pericarditis. So this is the way to look at it. Next slide. I've already explained. Okay. So we're going to use a case. We're going to use a case presentation again to outline what we discussed earlier. But to buttress what I said, to differentiate between STEMI and STEMI is simple. For patients with STEMI, which is on my right side, they usually have an unstable plaque that ruptured and lead to completely occlusive thrombus inside their coronaries. Some people who have ST elevation, we have definition for ST elevation, but generally we say greater than ST elevation greater than certain millimeters in 2 or more contiguous leads. There are ways we classify the ECG leads to tell us if it's inferior MI, anterior MI, lateral MI, and other. We're going to discuss that later. For the STEMI, they have a partially occlusive thrombus, and their ECG typically shows ST depression and or T-wave inversions. So when you see this in a patient with positive troponin, you start thinking what? STEMI. But if patient comes with features of chest pain that is severe enough to bring them and it's looking typical like myocardial infarction, but the ECG is still showing it's not showing ST elevation, it shows T-wave inversion or ST depression, but the enzyme is negative. You start thinking of what? Unstable angina. So that's the way we look at how to classify. So to outline how to diagnose the patient with MI, we're going to go through our third case now, Dr. Fotu.
Okay, so this case is a 52-year-old male who came in with severe retrosternal chest discomfort 5 hours prior to presentation, associated sweating and episode of vomiting, had a fainting episode. The pain is said to radiate to the left arm, a known hypertensive diagnosed a month earlier, not yet on medications, not a known diabetic, and never checked his lipid profile, does not smoke nor take alcohol, referred from another facility where he was given a start dose of aspirin, 300 milligrams, clopidogrel, 300 milligrams, and pulse rate was 102 beats per minute, BP 140/76, AVP was raised, the heart sounds 1 and 2, respiratory rate 30 cycles per minute, the oxygen saturation 89% in room air, fine crepitations heard in the bilaterally in the lower lung bases, and the troponin done in the referral hospital was normal. So what is the next step in the management of these patients? So the first one, should we take a sample for serum troponin levels, or should we send for emergency echocardiography? Do we do a 12-lead ECG, or do we do an urgent chest X-ray?
So look at the options. What do you think the first step would be for us, for this guy that was transferred to our facility, keeping in view the history that was given?
So please put your answers for us on
The
Q&A, please. Okay, so someone said number 3, that we should do a 12-lead ECG. Number 3, ECG, okay?
Yes.
So it means that we're following. That's good. So the answer here, do a 12-lead ECG.
So again, we said we describe chest pain, we get an ECG. The next step would be we should confirm with a positive enzyme. Right. So for us in cardiovascular medicine and internal medicine generally, everyone with ongoing acute chest pain, even if it look like ulcer or is described as ulcer, please, they must have an ECG within 5 to 10 minutes of arrival to the hospital. It's compulsory, even if the hospital is not an emergency department. Now, it's not every severe abdominal or epigastric pain that is peptic ulcer. There are instances in our own environment where people have had horrible heart conditions and they label them as ulcer or typhoid. Please, you may miss an acute coronary syndrome that way. Then the other thing we want you to remember is that there are what we call angina equivalents. I told you sometimes that some people don't present typically with the classical chest pain. They can come with the same ulcer pain we are discussing, quote and unquote. Sometimes they just come with fatigue, difficulty breathing, and it's still what? An acute coronary syndrome. So the risk factor profile of the patient, the sudden nature of the symptoms and all that, and the positive ECG and what, and the troponin will guide you and to how to evaluate this kind of patient. So this is a table, a slide showing us how to differentiate ST elevation versus depression and all that. We can see from this now, this is the normal ECG. That's a P wave followed by a QRS, followed by an ST segment and a T wave. So if somebody has an ST elevation, there is a pull-up of this ST segment. So it will be above baseline. This is our baseline, TP segment. Any pull-up above it is an ST elevation. Somebody has an STMI, they can have what? An ST depression, a dip in that ST segment. This is the normal ST segment, a dip. And that dip will be below this baseline. Then if somebody has an STMI too, sometimes they can just come with what? T-wave inversion. Just get this. The T-wave that is upright here goes down. So sometimes you look at this, you compare it with a baseline. And sometimes you can have concave ST elevation, as I showed you in that pericarditis case earlier. Concave ST elevation. For the MI, typical MI is usually more of convex upward or flat like this. But sometimes it may even look like this, but generally it's more flat or what, convex upward. So these are the ways we identify that. And we want ST elevation when we are diagnosing it. We want at least 1 millimeter, one small balls above baseline in the limb leads, and 2 small balls above baseline in the chest leads. And they must be present in at least 2 contiguous leads. What do we mean by contiguous? There is a pattern on ECG that tells us the location of what? The part of the heart that that lead is looking at. I used to say that ECG leads are like the proverbial elephant and 9 blind men. The 9 or 12. Elephant and 9 blind men, that is the part you are touching that will tell us what you are seeing. Exactly. So the lateral leads are 1 AVL, B5, and B6. They look at the lateral side of the heart. 2, 3, and AVF are the inferior leads. They look at the inferior part of the heart. B1 and B2 look at the septum. V3, V4 looks at the anterior wall. Yeah, so that's the way we look at it. So we need in at least 2 of them. So if you are seeing inferior MI now, you'll be talking about 2, 3, and AVF. Even if it's just 2 and 3 you saw, that's significant. If it's 3 and AVF you saw, that's significant. What shall be at least 2 in that group, 2 or more in that group of what leads. So that's the way we look at ST.
You have to memorize it.
And you have to memorize it. So this is the ECG of our patient. This is ECG. You have 10 seconds to look through at the ECG and tell us what your thoughts are. The patient we just talked about.
Please leave an answer in the
Please put your answer in the Q&A, please.
Q&A.
Okay, me, I'm not slouching. So, have we looked at the ECGs? What are our thoughts? So, most of them said number 3.
I think that's for the previous answer.
No, this is the recent one.
Okay.
They're choosing 3.
STEMI.
So somebody say ST elevation in the inferior lead, excellent.
Great.
Inferior lateral STEMI, that's manageable.
Half mark.
Half mark. That's good. So somebody Chukudi said ST elevation in 2-3 ABF, ST depression in B2, B3, B4. That's excellent. ST elevation in the inferior lead, depression in arterial lead. We have a lot of gurus on the webinar today.
That's
Thank
great.
you all. So next slide. So yes, this is how we group ECGs. This is how we group ECGs. We said they are contiguous leads. These are the ones that look at the inferior part of the heart, 2, 3, and ABF. That's inferior leads. For the lateral leads, we say B5, B6, 1, and ABL. For the anteroseptal, is B1, B2, B3, B4. So this way you will know which which side of the heart is affected. It also helps us to kind of guess which artery is likely to be affected. Yes. So it's an inferior STEMI. If you go back to the ECG, we can see ST elevation in the inferior leads, 2, 3, and ABF. 2, 3, and ABF. It's ST elevation here, ST elevation here, ST elevation here. In the other leads, what you have are what we call reciprocal changes. Yeah. So normally in the context of ST elevation in any lead, any other change you are seeing that is opposite that in other leads will be what? Reciprocal changes. However, if all the changes you are seeing are just ST depression, that's STEMI. But for this patient, what he has is STEMI. So ST elevation is the primary thing you should be reporting. Any other changes in the opposite direction will be what? Reciprocal changes. So this is inferior STEMI as the answers on the page are said. So what is the next test you want to do for this patient immediately? So please put your answers in the Q&A. Your answers, please. Let's see what you think. The next test you want to do for these guys. So we already have answers here. Somebody said troponin high. That's excellent. Thank you very much. Somebody, anonymous person said troponin high too. Thank you. So we're going to get the troponin. The fact that the initial troponin was normal doesn't mean we don't repeat another one. Let's be sure if we're dealing with MI. So we said cardiac troponin are available in the evaluation of chest pain. If you have a negative troponin initially and the patient has ongoing chest pain, you have to repeat another one within 3 to 6 hours because it takes some time from the peak onset of from the start of chest pain in MI for troponin to start rising. So we want you to repeat it 3 to 6 hours afterwards. Next. So, but however, there are instances where people have troponin elevation and they don't have acute coronary syndrome. So generally, that's where your history and the ECG findings should guide you. So it's not that somebody comes with chest pain, every other thing is not looking like from the heart, but you now saw an elevated troponin. We are not saying you should discountenance it, you should throw it away, but you should look at other reasons why the patient may be having elevated troponin. They can have myocardial injury from other causes. So some of the examples of elevated troponin can be from heart failure, can be from pulmonary embolism. Remember the case we presented earlier. Troponin was 0.9. It's a bit above the normal limit. Patient can have chronic kidney disease, bone sepsis, endocarditis, myocarditis, and they still are elevated. So the context matters. the presentation, the ECG, then the troponin. So for ST elevation, I think we have talked about this enough. Symptoms must be consistent with acute coronary syndrome. Usually, the pain is usually of more longer duration, more than 20 minutes. These people have persistent ECG changes. We are talking about ST elevation. Sometimes it could just be a new left bundle branch block, in which you now see widening QRS complex and all that. Then, of course, they will have elevated biomarker like troponin. That's ST elevation myocardial infarction. So this is another example of ST elevation myocardial infarction. In this case, you can see that the ST elevation is in the leads V1, V2, even up to V1, V2, V2, V3, V4, V5. So this patient has an extensive anterolateral myocardial infarction and it's ST elevation. The other thing you see in this patient is that they have pathologic Q waves. So we have Q waves in this. Q waves here, you can see those deep Q waves here. Deep Q waves here, apart from the ST elevation. So this patient has what? An extensive anterior MI. This patient is a recent patient we had just less than a week ago that came in and had coronary angio. Sometimes the way the ECG we see is a left bundle branch block. So you get widening QRS complex like this. You may not necessarily see typical ST elevation or depression, but the widening QRS already will be telling you that something is wrong with this case. So those are the features of ST elevation myocardial infarction. For non-ST elevation myocardial infarction, same thing, symptoms are typical. This time around, you are seeing downsloping or horizontal ST depression with or without T-wave inversion, and there is a positive troponin. You know, I already said, once you see troponin down in the context of abnormal ECG, you should start thinking of what? MI. It's just the ECG pattern that will tell you, is it what? STEMI or NSTEMI? Okay, so this is an example of an NSTEMI. We can see this is an anterior NSTEMI. You can see the extensive T-wave inversion from here down, V1. So generally, once you are getting anterior, septal, and lateral together, we just say anterior. So this is an anterior STEMI. You can see an extensive T-wave inversion here. There's also ST depression, horizontal ST depression, because this is the baseline here. And the depression is just below the baseline. This is the baseline here. It's a bit below the baseline. You can see it here. It's more prominent in V6. You can see that it's down. So we have ST depression and a T-wave inversion. This guy is also presented in last 1 week. NSTEMI coming in with severe chest pain, elevated troponin, retrosternal chest pain. So this is how to make a diagnosis of this. This is another one, NSTEMI in the inferior leads. We can see it in 2, 3, and AVF. This patient's T-wave did not go down like the other one, but you can see the downsloping ST depression here. Downsloping is slanting downward. You can see it there. It's also extending a bit towards the other side too. That's the anteroseptal side. But you can see classical ST depression of NSTEMI. Now for unstable angina, unstable angina patients, they will not get what? Your typical ST elevation on ECG. Their troponin level is fine. So, but they have typical symptom of ischemia that is occurring at rest. So this kind of patient, we tend to look at them in the context of where they were before. Some people may just come with new onset angina, but it's prolonged, like in MI, like more than 20 minutes. Or sometimes they have an angina before, maybe they've been having ischemic chest pain before, they don't have MI, but the angina is something that only comes with exertion and it must come with serious exertion. But now it's now becoming more frequent, or the duration is getting longer, or the effort they need to make before the angina comes up is now shorter. Like somebody tells you that somebody that we have diagnosed with ischemic disease before, but not MI, chronic ischemic disease. They used to have angina on walking 5 kilometers before. Now, if they just walk around their house, they already start having angina. They come in and their ECG is still not showing ST elevation. and their troponin is still fine, you say it's probably what? Unstable angina. So these are examples of what we call unstable angina. But just know that unstable angina patients come with serious pain too, and they are what? Their troponin is fine, and they don't have typical ST elevation or what? On ECG. So to continue with the case we presented, Dr. Fortune will go ahead.
Okay, so the troponin, the investigations of this patient, troponin 0.2 on present at referring hospital. On presentation, we had risen to 2.3, LDL 116 milligrams per dl, total cholesterol 230, triglyceride 157, all deranged, NT-proBNP 2000, creatinine 1.0, full blood count normal. So further care, he was nursed in cardiac position on supplemental oxygen. 10 milligrams of morphine and 10 milligrams of metoclopramide were administered stat. 75 milligrams of aspirin, clopidogrel were given, and clexane 40 daily were given to this patient.
So again, we've talked about chest pain. We said we must get a positive ECG, positive enzyme in the context of their cardiovascular risk. The next part is urgent medical treatment. So if you go through what was presented now, you will see that the initial treatment was quickly to give the guest, give some supportive care to the guest immediately. From the referring center, these guests had had loading doses of aspirin and clopidogrel. We continued the dual antiplatelets. Oxygen was given because oxygen saturation was low. We had to give something for pain. Metoclopramide can induce what's it called? Vomiting. So we gave metoclopramide just to treat vomiting. Of course, the patient had to be on anticoagulation because MI is a prothrombotic state. The patient can even have acute PE concomitant with your MI or DVT. So these are the initial treatment we started. So going forward, if you read, this is the history we gave you earlier. This was the history we gave earlier. So the next question will be, apart from the new treatment we have instituted, what other treatment will you give these guests in the emergency room? Please look carefully and choose your option. What other treatment will you want to give these patients in your emergency room? So please, what's the question? What's the question? Please go ahead, choose your options. Let's see. Somebody say option 1. Somebody else say option 4. Assumpta said option 3, excellent. Assumpta. Option 4, thank you. Kelechi said option 4. I'm going to explain which of the option is best very soon. Okay. Ahmed said sublingual nitroglycerin, bisoprolol, more that. So we'll look at that. Thank you. So there are quite a number of option 3 here. Anonymous attendee. Okay. Mr. or Mrs. Anonymous, thank you. Again, back to the treatment we have given. We said we have already given supplemental oxygen, morphine, metoclopramide, dual antiplatelet. Patient is on clexane. Also, before the patient got to us, the patient already had what's it called? Dual antiplatelet loading dose and all. So we're asking, what else are you going to add as part of initial management? So this is the approach. The initial management of a patient coming to us with acute coronary syndrome. We want you to remember this. The mnemonic is MONASH. we want you to remember that the patient should be on some analgesic, preferably opioid analgesic like morphine or fentanyl. Because they induce vomiting, you may have to add antiemetic. Also, we give oxygen if the patient is hypoxemic, only if the patient is hypoxemic. Generally, some believe that, oh, because of the mismatch and all that, you may just give oxygen to everybody. But sometimes some people come mild, it's just a chest pain, otherwise they look very stable, oxygen saturation 99, 100, they are not tachypneic or anything. They may not necessarily need oxygen. Nitrates can be given either by infusion, especially if they are hypertensive, you understand, or sublingual. So for nitrate, we avoid nitrates in the what? In inferior MI. Anybody comes into the emergency with inferior MI, we avoid nitrate because such people with inferior MI are prone to hypotension. Nitrate will just further increase the risk of hypotension in such patients. Of course, antiplatelets, as said earlier, loading dose followed by what? Maintenance dose. Maintenance for aspirin and clopidogrel at 75 milligrams. Then we must give them high dose of statin. High dose statin has dose. Atorvastatin, that is high dose, is 40 to 80 milligrams per day, while rosuvastatin high dose is what? 20 to 40 milligrams per day. Then the last one is that patients should be on anticoagulation. Preferably weight-based dose, 1 milligram per kg per dose. If the person is 80 kg, sometimes we give them as high as 80, 12 hourly. So, but that depends on the experience of each center. But they should be on anticoagulation. You can use heparin or enoxaparin. So our treatment in this patient that we presented earlier will be to add IV furosemide because the patient is also in failure. Remember, the patient had basal crepitations, NT-proBNP was high. Captopril 2 was also for the failure, but among the initial treatment that we listed earlier, we are not going to give a beta blocker too, because beta blockers should be avoided except absolutely needed in patients with inferior MI. Already I said we will not give nitrates because of inferior MI for the guests we presented. So, but we are going to give rosuvastatin. As said, we said we must give high dose statin. So 20 to 40 milligrams for rosuvastatin. So the only reason why option 1 is wrong is because it's inferior MI. And the only reason why option 4 is wrong is just because it's inferior MI. If you remember, the patient's heart rate is on the normal side, and we don't want to tip the patient into hypotension too. So those are the reasons why we choose our options. Please, next slide. So again, we avoid nitrates and beta blocker in inferior myocardial infarction. We also avoid beta blockers in patients with cocaine-induced myocardial infarction because this can be really life-threatening. If you give beta blockers in such patients, they will just get unrestricted alpha-1 activation, and patient can go into arrhythmias and die suddenly. So we avoid that. So for nitrate and beta blockers, inferior MI, as the case we presented, we avoid them. Next. So if you have MI, apart from what I said earlier, we listed 5 things. We said typical presentation, followed by ECG, followed by troponin level, in the context of their cardiovascular risk factor, making number 4. Then we give the initial treatment. The next is to assess for reperfusion. As stated here, time is money. Every minute or second with a blocked artery increases the risk of heart muscle death, subsequent heart failure, and or subsequent cardiac arrest. So it's not enough to place patient on clexane and aspirin and say that you are treating patient with myocardial infarction. If you don't address that blocked artery, the risk of muscle death and heart failure and heart attack increases. So you must reperfuse the patient if it is indicated. So what are the reperfusion options we have? Generally, we have 3 major reperfusion therapy, but we prefer that these 3 things should be done within 60 to 90 minutes of the patient coming to your facility. If you can't get that, you should refer appropriately to hospitals like ours, Cardiocare, that can get the patient reperfusion. So first line is percutaneous coronary intervention with stenting. So sometimes people get stents. So you come in, the patient gets the coronary angio done, you get ballooning. Sometimes you put a, sometimes some patients may need stents. For thrombolytic therapy, it may be an ideal option for people that have STEMI. STEMI is the only indication for what? Thrombolytic therapy. We're going to discuss that later. The most recommended reason why you should give a patient thrombolytic therapy is when they have STEMI and they cannot get to what? A center where they can do a PCI on time. So that's when you should have what? Thrombolytics. And the last option is coronary artery bypass surgery. This is usually reserved for people with extensive, extensive blockage in their coronaries, or people that have mechanical complications like ruptured wall of the heart, or people that are already having coronary artery disease and they're going to need some valve replacement and other reasons for cardiac surgery, ab initio. Some people, you may just go for emergency coronary bypass surgery. In the past, this used to be the only option for people with triple vessel disease, but even nowadays, especially people that have high surgical risk, they still go ahead and do percutaneous coronary angiography percutaneous coronary intervention for them. So next slide, please. So for thrombolytics, we have various types: alteplase, tenecteplase, and streptokinase. All three are in Nigeria. We use all three. We use the first two, alteplase and tenecteplase, in cardio care. Streptokinase is also available. So all three are available in the country. Next. So immediate priority after your initial assessment and confirmation of diagnosis and initial treatment offered. Those initial treatment offers should not be long. You should be done with that within 10, 15 minutes. Immediate reperfusion is the priority. And there is an established association between reperfusing the patient within 1.5 hours of first medical contact and favorable long-term outcome. Long-term outcome in terms of death, in terms of heart failure, and all that. Next. So normally the goal is immediate angio when the patient gets to the hospital. So the door to balloon time, that is from the time the patient comes into the hospital to when they get into the cath lab, should be less than 1 hour. That's the goal. But this is for places where you are capable of doing percutaneous coronary intervention. So like cardio care, you come in now, STEMI or N-STEMI, door to balloon time, from contact of the patient to when they go to see to the cath lab should be less than 1 hour. Yes. However, in a practice in my village or a general hospital in my locality where I come from, if you anticipate that this patient with STEMI or N-STEMI cannot get to where they can do PCI like cardio care within 2 hours, it's better you give thrombolytics first. Once you have given your thrombolytics, at least that will be helping with reperfusion before you can transfer to what? To a place like cardio care. However, if you are sure that they can get to that place within 2 hours, it's still better to transfer the patient. So that approach of looking at the time to get to where they can get PCI done is what we call a pharmaco-invasive approach. Such that if you know that it's going to take long before they get to where they are going, thrombolize them and send them for PCI. If you are sure that they can get to that place within 2 hours, you can transfer them to the place. But if you are sure they are going to more than 2 hours, thrombolize first, then please send them for PCI. And that PCI should be done within 24 hours. So again, just to recap, initial management that you do in the emergency quickly is Monash. For N-STEMI or unstable angina, we still do the initial management as we have outlined. We re-stratify them. What we mean by re-stratification is that it's not all cases of N-STEMI or unstable angina that needs immediate reperfusion. We look at the presentation and we use it to determine who should go ahead with it, who should continue conservative management. But in them, if they are high risk or deemed very high risk, we go ahead with reperfusion. But we don't give thrombolytics in patients without ST elevation MI. We don't do thrombolytics in patients with STMI or unstable angina, no thrombolytics. Either they do a PCI or a coronary artery bypass grafting. So risk stratification is very important. It just helps us to time when we should go to coronary angio in patients with non-ST elevation acute coronary syndrome. And it's usually based on the way they present and their ECG findings. Right. So for people that need urgent ones, people that are already coming in shock or cardiac arrest, like the second case I presented as STMI earlier, came in shock and all that, we had to go in and sort them out. Patients were already presenting with what? Ventricular arrhythmias. You can see multiple PVCs or VT on the ECG monitor. People coming with heart failure, have been issued. These patients, even if they have STMI, they go in straight to coronary angio. And patients that despite your initial medical therapy, they are still in severe pain. Pain is not getting better with drugs. To go in straight forward coronary angio. Right. Other ones you can temporize and look at it and all that. Next slide. So after you have treated any patient with acute coronary syndrome, that is not the end. Most atherosclerotic cardiovascular disease will lead to further atherosclerotic cardiovascular disease. So for stroke now, we say stroke begets stroke. For MI, same thing. Somebody that suffered an MI is at risk of further MI. Somebody that suffered peripheral artery disease at risk for both stroke and peripheral artery disease and MI. So atherosclerosis is a continuous thing. So you have to have what we call secondary prevention. Secondary prevention is just not about making the patient feel well. We also want to prevent a recurrence of what they have. So we have various aspects. The first one is lifestyle modification. We must cancel them on diet. In cardio care, we have our dietitian that is well used to this kind of very sick patients. Tell them about their salt intake, how to help with their cholesterol and all that. Then exercise. Now, people will wonder why are we talking of exercise? Exercise is symptom-limited exercise, especially in patients that still have some angina symptoms. So it should be symptom-limited exercise. This should be directed and guided by the clinician and the cardiac rehabilitation team. It's advised that people should stop smoking. So in fact, it's almost like a waste of time after coronary angiography and stenting, the patient is still smoking actively, and that person is coming back very, very soon. So you must stop smoking. If they are not taking alcohol, they must not start. If they have started, they should try to stop. Next. So as a way of simple mnemonic, we want you to remember this, ABCD. We say secondary prevention is as simple as ABC. Dr. Foti.
Aspirin, anti-angina like nitrates, beta blockers, blood pressure monitoring and control, cholesterol control, cigarette smoking cessation, dietary modification, and blood sugar control, exercise, and education.
Now, the last part is education. We here, and as we will advise you to, is that we must educate the patient. They must know what they had, how to prevent it, what the plan is going forward, how to prevent a recurrence, how to address some of their targets, because we have targets for all these, like blood pressure, diabetes control, cholesterol has targets. They must know that, and they must know the prognosis and all that. So you must tell the patient, you must discuss with them. These things are life-threatening. These things are life-altering too. People have PTSD after some of these diagnoses. So the cardiac rehabilitation team usually includes psychotherapists or a behavioral scientist and the like, just to talk to people. People have anxiety. Some people don't find it funny to sleep at night after they suffer heart failure from acute coronary syndrome, just because of your talking about this minor-shinitis now. So beyond educating them about smoking alcohol and controlling all their risk factors, this aspect is also very important. So these are our targets. For patients, all patients will be on high dose statin, as we have said. and we must reach an LDL target within 4 to 6 weeks. If we don't meet our target, we add other drugs that are not statins. In Nigeria, we have ezetimibe, and then we have PCSK9 inhibitors, particularly in inclisiran in Nigeria, that can be added to the statin to reach our target. But bempedoic acid is also an option where it is available. Our target, what we use in cardiac care is we use that patient with MI or stroke, they are already very high risk. So our target is very strict. Less than 55 milligram per DL, LDL target. That's less than 1.4 millimole per liter. For cholesterol control, our hemoglobin A1C target is less than 7%, and that's what's recommended worldwide. We prefer that patient should be on a GLP-1 agonist or an SGLT2 inhibitor like dapagliflozin or empagliflozin for their cardiovascular benefit. They must be on dual antiplatelet for at least 6 months. We use 9 to 6 months in our facility, but you may extend it, especially if patient has a very high risk of a recurrence or they've suffered repeated episodes. So, but if they have a high bleeding risk, you may even consider early withdrawal of aspirin so that the patient can continue on clopidogrel alone. So this recommendation is general, but on a case-by-case basis, there are instances where you may scale up the duration or step down the dual antiplatelet. So for other people that have concomitant atrial fibrillation, you understand, we may have to give them anticoagulant too. So generally, we avoid using dual antiplatelet with anticoagulant beyond the first 1 month. But they must be on anticoagulant and at least one of the antiplatelets, depending on the bleeding risk of the patient. So yeah, other drugs related to heart can come in, like beta blockers, especially patients do not have contraindication to it. Like we said, we don't give beta blockers in the PMI. So anybody coming with heart failure or they have hypertension, they may have to be on what? ACEIs, that's like Snopri and the likes, or ARBs like temistatan, valsartan. The mineralocorticoid antagonists can come in, especially if there is heart failure with reduced ejection fraction. So very important is cardiac rehabilitation. This is very important. This is a set of interventions that is given to people that have suffered MI, stroke, or they have chronic ischemic heart disease to what? To improve their symptoms, improve their quality of life, prevent recurrence of what they have, and improve their overall well-being generally. And it requires a multidisciplinary approach. There is the nutritionist or the dietitian involved. You can see physical therapists there. The psychology, psychosocial management is there, including occupational therapy, occupational assessments and all that. People want to know, what else can I do? For example, you put a patient after MI and they are stable through a stress test to help to gauge how much activity they can tolerate, right? Yeah. So that you will now see, you go to answer them, this is the amount of work you can do going forward and all that. So exercise training, as we discussed earlier. Tobacco cessation, it's not everybody just go and stop smoking. Some will not be able to stop without some interventions, including medications, including group therapy and all that. Weight management is important. Then the numbers, controlling the blood pressure, controlling the diabetes and lipid management is very important. So cardiac rehabilitation is there. Nigeria already has some places where we do cardiac rehabilitation. We have to do some form of this in our own facility. We have the nutritionist, we have our physiotherapy involved in management of this patient, and the other part of medical team takes care of all this. So our take-home message.
So our take-home today will be that acute coronary syndrome is the leading cause of death. It's one of the leading causes of death globally. Prompt recognition and initial guideline treatments, particularly revascularization therapies, save lives. Secondary prevention using the ABCD mnemonic is essential for preventing recurrence and improving long-term outcomes.
So thank you very much for listening. We're going to go through the Q&A and see where comments are what your comments are and address them one by one, your questions. So thank you all for listening. So there are some questions that I noted in the Q&A box. Somebody was asking what is the meaning of ADP? Thank you very much for the question. ADP is adenosine phosphate. There's a receptor for ADP on platelets, and clopidogrel, pasugrel, ticagrelol are antiplatelets that act on what? These receptors to prevent platelet aggregation and thrombus formation. Somebody else asked what's the difference between troponin I and troponin T. Troponin I and troponin T, both of them are cardiac enzymes. If you remember our physiology, they are components of your muscles. When the muscles is when the muscles are damaged, especially skeletal and cardiac muscles, these components can be released into the blood. By way of use, both of them can be used in diagnosis. Troponin I is commonly in the environment, but both of them can be used. It's just that it takes a bit longer time for troponin T to clear than troponin I, but regardless, the use is still the same. Somebody else asks, thank you for your questions. All, how do we differentiate previous MI from a recent one? If I get that question correctly, that starts from that's correct. That starts from the presentation. You can most times MI is not just by diagnosis. The patient already came with certain presentation, typical chest pain in the past that was confirmed and all those stuff with elevated troponin and all that. On ECG, that could be a bit tricky. After an initial MI, you may not see much signs again. Other times, you may see pathologic Q waves in the baseline ECG. So if you have the baseline ECG of the patient, it may help you tell that despite the history of MI before, these new changes are different from baseline, and what you are seeing is a new problem, different from what the patient had before. So I think it's dependent on your history taking skill and all that to know if the patient had MI before or not. For the ECG changes, depending on what the baseline ECG was. The baseline ECG of patient with previous MI may just show heart failure, may show bundle branch block, may even look similarly normal. Other times may have pathologic Q waves showing old infarct before now. And then you now have a new onset chest pain. You do another ECG, you are now seeing new onset ST elevation and or depression or T waves. You start thinking this is a new problem. I hope that answers the question. I think those are the questions. So to put us through some of the cases we have had, somebody asked if we are going to get some of the access to the slide. Of course, on Monday you should have access to the slide. Thank you. Somebody said, what do you think is about for many cases of slump and die case we are beginning to see in our society and worldwide? Yes, thank you for your question, Victoria. Yes, we cannot just say all of them are MI. There are other causes of sudden death like that, like what? Like stroke. People have stroke, people suffer MI, people have arrhythmias, abnormal heart rhythm that can just lead to cardiac arrest. It should be looked at case by case, you understand? Of course, people just need to check themselves more. So Cardiocare is there, like every other advanced hospital worldwide, to provide initial evaluation. These things don't just come out of the blue. People already have signs, both in their history, family history, ECGs, cardiovascular workup, that assesses their risk. So come on, let them check so that it's not when issues come up. That's why checks are there. It's not when issues come up that people are detecting. Most cases, you even hear people already know they have certain risk factor or certain underlying things. But of course, nobody knows what they have background. Is there a place for echo and chest X-ray? Now, yes, very important. The question on echo and chest X-ray. It's not that we don't do echo and chest X-ray. If you remember my chest pain algorithm, there's echo and chest X-ray, echo in the assessment of what? Chest pain generally. However, you don't need echo as the initial diagnosis of a patient with MI. We are not saying echo is not useful, but to say this person has MI, we don't necessarily need an echo per se. Generally, the history, the biomarkers, the ECG you should be able to make that diagnosis quickly, not waiting for when you are able to arrange echo and all that. Do you understand? So the aim of this presentation is so that you can pick this diagnosis on time and save life. If you are here in cardio care now, we can say we see this MI. While we are preparing for cath lab, we go and check the heart and all that. If you are in my village as a clinician or a health worker, you just want to know if the patient has MI so that the patient can get care as soon as possible. I hope that answers your question. Chest X-ray is also important. For example, now after that patient we talked about, had all these treatments and all that. Of course, we want to be sure, hope there is no congestion, hope there is no pneumonia, all those kind of things. So it's not that it's not useful. Ischemia and STEMI. Somebody asked, are they the same when identifying them on an ECG in terms of their feature? The term ischemia is not specific per se. Infarct is what you will see. Infarct is muscle damage. Ischemic changes on ECG is a more broader term. Ischemia can be end-stage like infarct, will still be subclinical that the symptom, the ECG changes may not be specific. So we are more concerned in this presentation about infarct. Infarct will give you MI, MI will give you ST elevation or ST depression, depending on if it is total occlusion or partial occlusion. But there can be ST wave changes that are non-specific and they are still due to ischemia. For example, somebody can have shock, that is very low BP and all that. They are in shock and they can have damage to their ischemic changes in their heart that can show non-specific ST changes. And if you are seeing such widespread ST changes that is not following a pattern, maybe one of the reasons why you may think this is just cardiac ischemia, not necessarily MI. But I think just beyond the scope of this presentation. How long does it take for a patient to be on clexane? Generally, if you admit any patient with acute coronary syndrome, they should be on anticoagulation for the duration of the admission. So can they do clotting profile as long as they are on this medical anticoagulation? Clotting profile, if you do it as a baseline test, generally in your facility, no problem. But clotting profile does not tell you much as about what's it called, the use of clexane per se, because by nature, clotting profile may not say why a patient with clexane will bleed or not. So you don't necessarily clotting profile to monitor such patients. What screening opportunities are available at Cardiologist, especially members of this and family that may not have health insurance? Just to be safe after listening to these symptoms and signs. Thank you, Anonymous. Try to put your name so that we'll know you. You can get access to our PR manager. Whatever screening opportunities are available, we'll let you know. Is coronary artery angiography same with PCI and intervention? Excellent question. Another Anonymous. Try to be putting your names in all this so that we're ready. Just try to be putting your names in this presentation so that we will know you. Coronary angio is the procedure. The intervention that is done inside the procedure is a balloon angioplasty with or without stenting. Angio is a test. You put a dye through the patient's blood vessel that will outline the coronary arteries that supply the heart. Through that imaging, you can detect if the patient has a blockage or not. Once you have seen a blockage that is significant, you want to intervene by opening it up. You can open it up with a balloon and follow it up with a stent to keep it open, depending on the nature of the blood vessels and all. So the angio is the diagnostic procedure. It can be combined with a stent or not. Everything together, angio plus stent and all that, is called percutaneous coronary intervention. I hope that answers your question. What's the relationship between diabetes and acute coronary syndrome? Diabetes is a risk factor for acute coronary syndrome, as simple as that. What's the difference between cardiac arrest and heart attack? Excellent question, Blessing Oga. Excellent question, Blessing Oga. So cardiac arrest, if you have attended our night Abuja Cardiovascular Symposium, we say cardiac arrest is an electrical problem. Heart attack is a what? A pipe problem. The pipe of blood that supplies the heart is where the problem is in heart attack. Cardiac arrest is what? The rhythm of the heart. Is the heart stopping suddenly? That's cardiac arrest. Heart attack is what? The pipe problem. Blockage of blood vessel to the heart. Heart attack can lead to cardiac arrest, not the other way around. Heart attack can lead to cardiac arrest. So cardiac arrest is what you say is like the end stage of everybody. Somebody will just die. It's hard to stop. So, but heart attack is what? Somebody coming with severe chest pain and all that. They have a blockage to their what? To their coronaries. But you can have instances where people will have what? A heart attack and it will lead to cardiac arrest immediately. But just know that one is a pipe problem, the other one is a reading problem or an electrical problem. I hope that answers your question. Thank you, Dr. Leslie Danlami from Babcock. Okay, yes, somebody asked if MI is synonymous with myocardial infarction or not. Yes, it is. Thank you very much. Anonymous again. So thank you all for listening. Then we'll just share some cases that we've managed with you so that you, at least, like somebody asked what's the difference between coronary angio and PCI. You're going to see that displayed now.
Good afternoon, everyone. I hope you really enjoyed the last presentation. I will be presenting on behalf of Dr. Iseto I. Iseto. I want to talk about interventional cardiology in everyday practice, where medicine meets surgery. I'm Dr. Taiwo Folashade Elizabeth. I work here in Cardio Care Multi-Specialty Hospital. So why is this conversation matters? Hypertension is the silent engine behind most cardiac catastrophes. From ECG changes to sudden death, we can see from the last presenter how we often miss these early signs. So there is need for early and integrated interventional strategy in the hypertensive population. So who we have? We are Cardio Care Multi-Specialty Hospital, flagship of the Limi Hospital, founded in 1982, National Center of Excellence for Cardiovascular Care. We've done over 1,500 successful procedures from stents, ICD, CRTs, pulmonary embolism intervention, and we are the first to perform left bundle branch area placing in Nigeria and West Africa. And we are located in Abuja, 90 minutes from anywhere in Nigeria. Yeah. Okay, I want to quickly talk about our heart failure support group. In cardio care, we have heart failure support group. The meeting is usually first Saturday of every month, where we meet with our heart failure patients. We have educational support, educational topics with them. We give them a forum for community engagement. We meet with the caregiver. We give them a venue for them to know that they are not alone. So you can send in your patient to us, irrespective of where they are. You can let them join the support group. I can assure you they will not regret joining the support group. Usually first Saturday of every month. So some of what we do at cardio care for ischemic heart disease, like my colleague has presented, we do coronary angiography plus stenting. For abnormal slow heart, we do pacemaker, advanced heart failure and sudden death. We do ICD and CRT implantation. For prevention of amputation, we do peripheral angiography. And treatment and prevention of thromboembolism, we do pulmonary embolism management. We put IV filters. And diagnosis of an unexplained syncope, we put loop recorders, especially for arrhythmias that are not frequent. And we do renal denervation therapy for resistant hypertension. And then we do cardiac surgeries. Last year, we held our Night Abuja Cardiovascular Symposium, the largest symposium in Nigeria, and the next one will be December, the second week of December. Last year, we hosted over 1,500 healthcare workers, nurses, pharmacists, and all. So this year, God sparing our life, we are expecting each and every one of us to participate. So we want to quickly take us through some of the cases we manage. Like we manage a 43-year-old male hypertensive diabetic with silent ischemia in, the atypical presentation of myocardial infarction, especially in female, in elderly and diabetic patients. They may not present with classic symptoms. Like this patient, he has widespread ST segment elevation in laterality. He did not present with any symptoms, and then he was able to have CAG plus PCI done. My colleagues have talked to us about this algorithm. If you have any patients with MI, please refer them to us. Let them benefit from quick intervention, please. We also had a 41-year-old person with chest pain on Christmas Eve, and on examination on angio, he had occlusion of right coronary artery, and he had stents put in place. He had RCA total occlusion, and then he had revascularization done. So never ignore chest pain. Some patients will present with ulcer-like symptoms. For anybody with chest pain, ECG must be done. Bearing in mind that we have atypical presentation of MI, especially in diabetic patients, in elderly and females. So all patients with chest pain should have ECG done. Okay. So some of the complications that can arise include arrhythmia. you can look at this ECG that I just displayed. This patient had MI and then developed arrhythmia afterwards. They non-hypertensive diabetic. It developed non-sustained PT, which later progressed to BT. Patient was cardioverted and then patient did well. And then also we had a case of BT that was aborted also. So we talked about pacemaker and ICD insertions. We do all this here. Patients with bradycardia, patients with heart failure. You can send them to us. Patient that has been on heart failure medication for 3 to 6 months with no response, no single response on guideline medical directed therapy, and the patient is not doing well with EF of less than 40, less than 35. Send them to us. They will benefit from cardiac device. Then also for patients with this, there is a patient that we manage after IC, the patient had optimized heart failure treatment and the patient did well. We had several cases of electrical storm that we have managed for us in cardio care. Generally, it's been said that electrical storm has a poor outcome, but in cardio care, it has a good outcome. We manage several cases and they are doing well. They are on follow-up in clinic as we speak. Also, we had a 58-year-old woman that had ICD and ICD done, and then the patient is doing well. We are the first to do left bundle branch area pacing in Nigeria. Okay, we had a 52-year-old man with unexplained recurrent syncopal attack. Unexplained syncopal attack. So on examination wasn't eventful. ECG showed morbid type 1, but it was the loop recorder. It was the loop recorder that picked the arrhythmia of the patient. So if you have patients with unexplained syncope, then infrequent symptoms, you can send them in for loop recorder insertion. And studies have shown that it can be recommended in cryptogenic stroke. Okay, then we have some intervention with pulmonary embolism with hemodynamic compromise. We do IV filter plus thrombolysis. We manage a case of acute abdomen due to renal thrombosis in post-tensive patients. And we have cases of peripheral angiography that has been done successfully in our center. Okay, this is a case of pulmonary artery angiography and intervention. You can see the pulmonary clot, and then the second image beside is post-procedure fluid. Okay, this is a case of IV filter that was placed for a patient, and this image was a case of patient with a known diabetic patient that has peripheral angio done plus or minor PCI. We can see the leg before and then the leg after. So why choose cardio care? Cardio care is a pioneering, accessible, and responsive healthcare. Door to wire is less than 60 minutes emergency PCI. We have multi-specialty team, cardiology, nephrology, ICU, nursing, physiotherapy, radiology. And we have transparent care plus feedback to referring physician. We have mechanical circulatory support, intra-aortic balloon pump, and then we do monthly CMEs, teaching hospital partnership, and webinars, just like we just finished one now. Okay, we do postgraduate training too. We have multiple training MOUs with teaching hospital and public institutions like Bafemi Awolowo University Teaching Hospital Complex, University of Port Harcourt Teaching Hospital, the Federal Teaching Hospital Katsina, and all. Then you can do your observership posting for senior registrars and interested consultants here. Okay, we had our Night Abuja Cardiovascular Symposium last year, and this year by December another one is coming up. So cardio care, you don't have to send your patient abroad. We are located at 5 Giza Close area, 11 Gariki, Abuja. A telephone number is displayed. You can reach us, even with the MD on this line. Okay, thank you.